We're going to talk about the thumb today, obviously, which the thumb is a very interesting topic in general. If you think about it culturally, what are the different symbols that you think of with the thumb? Right? Thumbs up. Right, does anyone know where that came from? Fonzie, yes. He did have a God complex. That's a hint from where it came from. Anyone know? Trinity symbol is actually this. Okay, because you have the thumb, the Son, and the Spirit, right? So that's actually the okay sign. Everything's good because God's with me, right? Kind of interesting. Thumb in Greek mythology, it was the decision maker because it was the head, it was the Zeus, it was the god, and so that's why everything was good or bad, right? So if you do this, I will stop my talk and I will go to work. But it's interesting because most of us, imagine this, you're a tourist, you're trying to communicate, you don't really speak their language, and what's maybe kind of a universal thing that you would do to say that everything's okay? That's offensive in quite a few cultures. So be careful with the thumb. So just understand that the thing is interesting, the how thumb and the hand and communication is with cultures, but the thumb is generally considered the most important part of the hand. It's used in over half of the uses of our hand involves the thumb. So we'll talk a little bit about the thumb today. This is a 65-year-old female who came into our clinic complaining of hand pain. She stated that it was worse at night, but more and more it's been progressive in her life to not allow her to perform her days of living, her activities of daily living. She takes ibuprofen for the pain in her hand. It helps, but it's been progressively worsening, and it hurts to open bottles. What do you see from the x-ray? What are your thoughts from the history, other questions, exams, things you'd like to look at and consider? Obviously, my opening has kind of pointed the finger a little bit, pun intended.
Is it typical for osteoarthritis type symptoms to be a little bit worse at night, tend to flare up at night, given the age? And
Why is that? Why is osteoarthritis worse at night?
Actually, I don't know.
Anyone?
Make it up, but I think you have a better answer.
I'll just make it up.
Okay.
No, anyone have an answer for that?
I don't know why, but I think that the pain that the other things tend to distract you while you're alert and active during the day.
Mm-hmm.
When those fade into the background, this nagging, aching pain comes to the surface.
Yep. There's actually one other reason, and it's a neurology reason, and I'm going to throw up because I just said that neurosurgery has a reason for something. But I'm just joking. No, so it actually has to do with the autonomic and the autonomic nervous system, if you think about it, right? While we're active during the day, which is our usual autonomic nervous system that's working? Yeah, sympathetic, right? We're working, we're active, we're solving problems, we're thinking, we're planning, we're doing, we're acting, right? We're responding. Then at night, what changes? Right, we go to parasympathetic. What happens with parasympathetic in our body? What changes? What does it do to our vessels? Right, vasodilation. What does vasodilation create? Blood flow. What's the point of that? Why is that a good thing? Healing, it's recovering at the end of the day, right? So typically it's worse at night because our body's trying to fix what we did to it during the day, and so we get swelling, specifically in areas that we used a lot of, and then those chemotactic responses will cause local responses of swelling, right? So we see that. So it has to do a lot with the autonomic nervous system. Okay, worse at night. Anything you see on x-rays or anything you see with exam that you'd like to point out? Go ahead, be brave. Anyone? Go ahead.
CMC grind test.
Okay, good. CMC grind test. Anyone know what that is? So basically, you're going to take the thumb at the main metacarpal. You're going to push it against the trapezium, and you're going to grind it. Okay. Patients will hate that. Specifically, here you can see at the base here, where the thumb meets the trapezium. She's worn through the radial half of the trapezium. So she's missing bone, right? So we can see severe osteoarthritis, grade 3 into grade 4, because there's pancarpal arthritis associated with it. And so this is some severe arthritis. Has pain opening bottles. Why is that? Opposition, right? Good. Difficulty with ADLs. What does that mean? Yeah, basic activities of daily living. Why is that difficult?
Grasp.
Okay. I need 2 volunteers, 2 brave volunteers. I'm going to cut your thumbs off. No. Any volunteers? Okay. Come on up. Okay. Let me see your hand. Just put your hand out. You okay if I put tape on it?
Yeah, fine.
You stepped up first.
This side too.
Oh, both.
Oh,
Wow.
both.
Turning me into a monkey.
Are you gonna cheat? Just painter's tape. Don't break it.
Okay.
Okay.
Your job is to open up the bottle and put the straw in. Go. Good. Notice that you could still do it. Why? Because you could still use your thumbs.
Yeah.
Okay. Now, even though I limited mobility, we're now going to make it to where your thumbs cannot grasp at all.
Have to use my teeth. No teeth.
Yeah, go ahead and start on it.
Go ahead and start.
Mm-hmm.
It's going to be a long day.
Mm-hmm.
That was a lot harder.
Harder, right? Good. Go ahead and you can take them off. Thank you for coming up and showing it. You can see how they acted. Notice they were still able to function, right? But was it more difficult when you took your thumb completely out of the picture?
Yeah.
And what's interesting, you saw they started using the fingers and they started using elbows and arms, right? That's what patients will start to complain about. They actually, that's how they do their shirts. That's how they do their zippers. That's how they do their hair, because they're no longer actually using their thumb at all. They're using their fingers, right? So you're still able to function. So they're not like they're starving and sitting there going, my thumb's ruined my life. I can't survive. But it definitely made it more difficult and it took them longer, right? So kind of the interesting thing is how important the thumb is for our daily activity. So when we talk about basilar thumb arthritis, CMC, that's the second most common arthritis of the hand, the first being the DIP joint. Now, if that's the case, shouldn't we have more people coming in and complaining of DIP arthritis? Do we see that a lot in our clinics? Anyone?
I think you see it with, the fingers are turned and sort of, sometimes it's all the last DIPs, but I don't think it's as much of a functional problem as the thumb. Like,
Exactly.
People are going to complain. I mean, as we get a little bit older, we've always been something, right? But I don't think they're going to complain until really ADLs get affected. And that's going to.
And that's the key thing is, right, the amount of function that we use for our thumb versus our DIP. Really, DIP, the main function is just that terminal grasping. So people who are rock climbers, right, they'll use that a lot, obviously that grip, but usually, for the most part, you don't do a ton with your DIP joint, which is often why if you get an amputation, a partial amputation, we just usually just trim the edge and say what you've got's what you got, and patients are fully functional. They don't even, oh yeah, that's right, I forgot, I had this cut off by a saw 10 years ago. I totally forgot about that. And trust me, I've seen that in clinic where I say, what happened to your thumb? Oh yeah, stupid accident, right? My wife told me not to do that and I did it. That's what happens, right? But we don't really notice that because the DIP joint isn't as functional. It's not as important. And honestly, if you get arthritis of the DIP joint, what's our response? How do we fix it? Refuse it, right? Right, the neurosurgery answer, just fuse it. It's more common. Men don't have it as much as women. That tells us that women are just more active and more functional than men. No. It just simply means that there's more risk factors, right? It has to do with genetics, has to do with the cartilage. We also see it's more common Ehlers-Danlos syndrome. And for those with elevated BMI, I tried to find out why this was the case. And I couldn't find the answer. Obviously, I've got some theories as to why.
There's a hormone secreted by fat that's supposed to predispose us to.
Yep, that was the one that we could see. I wasn't sure if that was the main reason, but that makes sense, right? But yeah, definitely higher incidence and higher BMI. So, why is osteoarthritis common in the thumb versus the DIP? DIP, obviously, we do a lot of gripping and lots of pressure through it, but the biggest reason is because we take 13 times whatever we're gripping through the thumb goes in our hand goes through the thumb. So let's say you're picking up a bag from Walmart and you're pinching it and you're holding it and you're like the strong man that's trying to carry all the bags, from your car, because you don't want to take more than one trip, right? So you're carrying all of that, whatever that weight is, times that by 13. Right? However hard you're pinching. For me in surgery, I think about that all the time, how tight I'm gripping the tissues as I'm throwing a suture. Should I be gripping it that tight? Is it really causing havoc to my hands? And the answer is yes. Actually, surgeons have a higher incidence of CMC arthritis because of the amount of pressure we use in our hands. So that's one of the causes. So as we look at the pathoanatomy, this is a picture of the trapezium. The trapezium is the bone that's on the thumb side. That's basically like the anvil of the hand as we pinch and grasp and do things with it. Yes, it goes through the phalanges, but it really connects to the body through that trapezium. So this is kind of the anvil. And that ends up kind of being the main issue is the osteology of that trapezium. The cartilage really just wears out. And as that wears out, it pushes and wears out on the base of the first metacarpal joint as well. And that'll cause some wearing down. And what ends up happening is there's a ligament here called the volar anterior oblique ligament, or the beak ligament. You can see it right here on the volar aspect here, where what happens is that becomes either attenuated, tight, or actually torn. And when that happens, you get some volar subluxation of that CMC of the metacarpal on the trapezium. And as that happens, you get that abnormal motion. Right, as you get that abnormal motion, causes the cartilage to wear out quicker. As the cartilage wears out quicker, obviously that's where you get your osteoarthritis. So the question where it comes of when you pop your knuckles, does it make a difference? We've shown that it doesn't, but if you pop your thumbs, does that make a difference because you're subluxing it? They actually have shown that if you do pop your thumbs, which I am guilty of, it's kind of actually subluxating and irritating that volar beak ligament. We deal with classification. It's really more of a X-ray based classification system, which has to do with, on the far left, you'll see there just a little bit of joint space narrowing as you see the metacarpal on the trapezium. And as you see, the saddle joint becomes more of a saddle or a pencil cup. Then you start to see some bone spurs that are greater than 2 millimeters. That's a grade 3. And then grade 4 is when you have trapezium and then the subtrapezium, trapezium scaphoid joint, where it starts to be arthritic elsewhere. So grade 4 becomes difficult because it's a little bit difficult one to treat. So you do want to catch these a little bit earlier than grade 4 if you can get to that point, because then it's a little bit difficult to manage that. So treatment options, same thing we always say in orthopedics. This is where neurosurgery will make fun of us, and it's appropriate. First thing we say is, well, don't do it, right? If it hurts to pinch or it hurts to do this, then don't do it. And I always joke with people that, yeah, that's the funny paper's response when I went to the doctor and the doctor told me it hurts when I do this, and the doctors just said, well, don't do that. That's kind of the big joke that we all say. But we know that that's true. In osteoarthritis, whenever you're creating pain or inflammation and you do that, it causes a cascade. Not only does it hurt while you're doing it, but it hurts you an hour later, 6 hours later, 2 days later, right? Because those cytokines are out in the body wreaking havoc and stimulating inflammation and irritation. So it does really mean if it hurts to do something, don't do it. So frequently, that 65-year-old that we showed at the very beginning is someone who does a lot of needlepoint. Hurts when she does needlepoint. You try to tell a 65-year-old woman that likes needlepoint not to do needlepoint. See what they say to you. But realistically, that's the discussion you have to have with them as well. Okay, then what are your options? So modifying your activities. Bracing. How do you think bracing helps with the CMC arthritis? How would that help? Therapists, specifically, you guys make a lot of braces that help patients. What are your thoughts on bracing for the thumb?
Stabilizes the joint to reduce irritation in that
Right.
area.
So especially if the problem is that volar oblique ligament, right, is subluxating. If we are just letting it subluxate, it's going to continue to be worse. Okay.
I think it's also helpful for the patient to get a constant reminder of areas that they need to stay in.
Yep.
In motion.
Yep. As we deal with tennis elbow, for example, you guys know that tennis elbow brace that people wear. Does that do anything? No. All it does is whenever they activate, it tightens and it reminds the patient, oh, that motion is going to worsen what I'm doing, right? So braces have a lot more of a reminder than actually stability and benefit. There's, arguments both ways. There is some benefit to it, but for this one, for me, it's allowing them to still oppose, but reducing the amount of opposition they're putting through it, right? So really, this is creating a little bit more of an activity modification. It's making them change a little bit, but it does make a difference. Most of our 65-year-old needle pointers that come in and they're able to use a brace, they're able to still do needlepoint. It just reminds them not to pinch as hard, but they're able to still grip because they're using their finger against the brace rather than their thumb against their finger, right? And the last one that we often talk about is injections. But again, the downside with injections is, are we worsening arthritis? There's data to suggest, as we've talked about with knee arthritis, that it actually does cause the arthritis to progress, but the data isn't fully clear on that. It's a question of, number one, what local agent are we using in the joint? Because if we're injecting with a lidocaine, that actually has been shown to be chondrotoxic. If we're using a bupivacaine, it's less chondrotoxic, but is that the cause, or is it the steroid that causes it? We don't fully know. We do know that if you give an injection, our patient's going to use their thumb more. Yes. Is that going to progress arthritis? Yes. So is it the injection or is it the continued use? Right? You be the judge. All right, CMC arthroplasty, right, which is this, right? No, that's a knee. That's a knee replacement. That's not arthroplasty. I wish we could do that. Then that'd be pretty sweet. So what is CMC arthroplasty? Is anyone well versed in this or know what joint replacement of the hand is? I mean, we're surgeons, right? Orthopedics. All we just try to do is just replace whatever we can. Right? So does that even make sense to do that? Anyone? The gold standard of what arthroplasty actually is actually not what you think. We don't just replace the ends of the bone and let them rub, just like we do in hip, knee, shoulder, and basically every other part. What it is basically bone removal. So we take away the anvil, we take away the trapezium, and then we try to find some way to support the joint after we've done our damage. So remove the bone, and then let's figure out what to do with it after that. That's basically what CMC arthroplasty is. The gold standard over the past 20 years has been what we call a FCR, interposition arthroplasty. And there's many different ways to do this. Basically what you'll see right here is an example of the FCR tendon, where you actually will harvest, so you'll make an incision, obviously where you're doing your thumb, you make an incision up here, cut half the graft, do a tendon stripper, and then pull it back out the thumb, and then there's 3 or 4 different ways to do it. One is to just weave it through the bone where you drill holes and weave it around so that use the tendon to hold the bone up so it doesn't just fall. Because you imagine if you take that bone out, the metacarpal is just going to collapse, right? But the thought is if you use the FCR and you can pull it up and attach it up high, you're going to suspend it using this tendon graft. Okay. The other way you do it is what's called an anchovy FCR arthroplasty, where you take that graft, you pull it out, and you actually weave it on a needle, and it make it look like a ribbon, and then you shove it in that area and you close it. The idea that you've now created the FCR tendon as a spacer, so to speak. And over time, that becomes this glob of tendon. Or you have this one, which is more common, that you're suspending it with the FCR with a graft right there, and then you leave that open. And that's been kind of the gold standard for many, many years, but we're starting to see that change, because how much benefit is there to take half of the FCR tendon, which is a pretty important tendon. Helps with wrist flexion, wrist deviation, which is very important when we're grasping things from an extension to flexion position, right? Very, very important tendon. And so some of the new gold standard is what we're calling a suspension arthroplasty, where same thing, we go in, we take out the trapezium, but then we're going to suspend the CMC on a type of a trampoline or a tightrope. And so what this CMC arthroplasty or suspension arthroplasty is basically you're creating some sort of trampoline. And the way that we've done this in the past is the different tendons that run past there, you can actually suture them and create a trampoline. But this new one, this new technique, which has been out for a little bit now, allows us to actually go in and support.
The trapezium is removed.
Sorry, I hate this.
A McGlamry elevator can be used to facilitate removal.
Sorry. So you take out the bone, which makes it look super easy.
Place the
It's not that
guide wire
easy.
from midline on the radial base of the second metacarpal through the far cortex, stopping just after the far cortex has been breached.
So basically what we're doing now is we're going to pass a suture into the metacarpal, which is going to be a suture.
Care is taken to place the guide wire in an oblique fashion, exiting distal to the second and third metacarpal interspace. This allows move the guide wire and drill with the fluted drill to the.
Thank you very much. So then once we drill through that, we create an area where we can put a suture that we ball up. We ball up the suture on the opposite side, the whole reason being we don't want some big polyethyl ketone screw or a metal screw to be in there, because we don't want to have another implant we have to deal with, but instead we just push in a suture that will ball up at the end. Once we place that suture, we remove the cannula. It talks about the depth to make sure we have it correctly. Confirm on x-ray that you're past it. Once you pass your suture, we'll pull it back, and as we pull it back, that bundles. And as it bundles, it becomes tight and it stays. So now you've created your anchor point. And then with the anchor point, we'll then suspend the base of the thumb. Now there's different ways you can do this. Do you suspend it here or do you suspend it here? Realistically, there's debate as to where you suspend it, but the whole idea is you're creating a continuation or a communication between these two bones, and you're making it so that metacarpal doesn't go down into that space that you've created. And that's realistically it. That's what we call that suspension arthroplasty, with the idea being is immediately post-operatively, you're actually able to start moving them pretty quickly. And so that's what we're seeing right now is being, as you talk with a lot of hand surgeons, kind of the future of joint replacement in the thumb. So this one right here is an example of that first part where we drill into the second metacarpal. So you can see here, trapezium's missing. This is the base of the first. That's the base of the second. We've passed that suture wire there. And then here is where we have it into the second metacarpal. We then make that drill into the base of the first metacarpal. You can see the joint space right there. And as we put that drill in, we then put our anchor there. We take that suture, we place an anchor that will hold that suture based off of the tension we place. So what we end up doing is we bring the hand into a little bit of adduction, not a ton. We don't want to flex it too much or pull it out. If we pull it out too far, when once we lock it, you can't adduct it because you've locked it into that joint. So you kind of want to get it to where it's functional, and then you fire that interlocking or that interference screw, and then at the very end you can see the trapezium's missing, and that hand is the thumb is right where it should be because you have that suture suspending it in place. The whole idea being what you've done is you've removed the anvil that is hitting the two bones together, creating that osteoarthritis, and now you're not having that subluxation of the metacarpal. So now you can still pinch, but what you're pinching against is the second metacarpal and the suspension arthroplasty. And so we're really seeing this a lot now, and this is kind of the gold standard as we're going towards joint replacement of the thumb.
Dr. Pitts?
Yes.
What's your thoughts? I mean, PTs are kind of known for strength, right? Like, get it stronger. You know, that's kind of what we go to. And I haven't seen a ton of cases, maybe 5, but I see a lot of these cases get better just by improving grip strength and the idea like offload the joint and get muscles stronger
Yes.
around it, doesn't change the OA in the joint, but potentially offloads it to reduce pain.
Yes, absolutely.
I'm curious,
true.
like, what's your thoughts
So
on
in this case, this lady, as you've gone through that she was a grade 4, right? She had that pancarpal arthritis. She'd worn one half of her bone through. She's one who failed physical therapy. So in her case, this is not what we did. We did a replacement. But you're absolutely right. And that this is what we place in theory with hip arthritis, with knee arthritis, with shoulder arthritis. Our first go-to always is, what is your motor function? If your motor function is not good, the example we always give is a landing gear, right? For your landing gear in a plane, if your landing gear is not stable, when you land, every single landing is going to be rough, right? But the better your gear is to support your plane, your landing is going to be a little bit easier. And so with knee arthritis, if your knee is weak, right, and you're landing and you're not having that support, your landing gear is terrible, and it's going to cause a whole lot of subluxations, abnormal motion you don't want. So tighten that up, and doing a lot of therapy to make that stronger obviously is more supportive, and it's going to have better landing, right? So yes, that principle still applies here to the hand, and so we do that for a lot of patients. This specifically, this lady, obviously we didn't because of that pancarpal arthritis, but absolutely I did neglect to talk about therapy. That does make a benefit, but in her case, it just wasn't something we did. But great point, thank you for pointing out what I missed. That's good. So then the question becomes immediately after this, what are you allowed to do? The gold standard with that FCR that we were doing before that FCR interposition arthroplasty was we were immobilizing him for about 6 weeks, letting that soft tissue heal, and then eventually getting him back to movement. But what, therapists, what do you think about 6 weeks of immobilizing a hand? Right, recipe for disaster, right? So we don't do that anymore. So this was a systematic review that looked at suspension arthroplasties. What are we allowed to do? They looked at a bunch of different studies and noticed if we mobilize 2, 4, 6 weeks or more, is there a difference? And the second question they ask is, well, if we do mobilize them or we don't mobilize them, what type of mobilization should we do? A rigid, semi-rigid, meaning should we allow them to have any motion? Should we allow them to have no motion? And they showed that there was no benefit for mobilization greater than 6 weeks, and there was also no difference between 2 or 4 weeks of immobilization, which is, to me, this wasn't their conclusion, but to me, if there's no difference between 2 and 4, then get them moving at 2. And actually, there's other studies that have been published now that say, well, if they're good at 2, get them moving right away. Because really, what does 2 weeks do for soft tissue rest? Not a ton, right? And so with these patients, as we see more and more of these, because this is kind of the new common procedure, we want to think about how quick can we get them moving, getting them back to their ADLs. Because the more you immobilize them, what we're seeing right here with bottles, pill bottles. Imagine if that was a pill bottle I asked you guys to open up, rather than just a simple water bottle and putting a straw in, right? It's a little bit more difficult. And how are you going to be able to take your medications and be able to function on your own, right? So the goal of dealing with the thumb is we need to get them getting back to their ADLs as quick as possible, whatever that is. If that means that they can continue doing surgery, continue avoiding surgery by doing non-operative managements and doing exercise and activity modification and injections and bracing, hey, then for the vast majority of my patients, actually, that's what I do. I do surgeries on this very infrequently because I actually do fairly well, but this is the surgical treatment just as we talk about it. Any questions?
What are expectations for grip strength growth with this? I mean,
Great.
I assume there's been a decrease in the...
It does. We've seen a decrease in about 15 to 20%, but for the most part, in the patients who are using this, they don't notice that because their grip strength has been dropped for years. So it becomes more of a question of, is this compared to the contralateral hand that's normal, or compared to where their preoperative state was? And that's the hard part. We don't see a difference between their preoperative state. It's their pre-arthritic state is the question.
Was there a version of this surgery a long time ago where palmaris longus was harvested and kind of rolled and became a space occupier?
Yeah, we just noticed that that the FCR is right next to it, so in order to do that, you'd have to pretty much take the entire palmaris longus. So rather than completely taking that tendon, we just decided to switch and take the FCR. That became the gold standard.
Do we have any problems with the cable or suture eroding into the base of the metacarpal? Seems like
Yeah, we haven't seen that yet, and partially because, again, I don't have any conflicts of interest with Arthrex, but they have what's called a fiber tape. So it's a very strong suture, but it's not a suture ball, it's suture flat. And so it creates, and as you have those two suture tails, as they come together like this, they actually create a flat base, and so it's less wear. We haven't seen any reports where that's wearing through the bone yet. And this has been out for about, I mean, the suture's been out for about 10 years. The suspension with that fiber tack is only a few years out.
What do you think about grip strength being a new vital sign? With the research coming out saying that grip strength is correlated with mortality. What do you think?
Yeah, I think it's a fascinating function because realistically, doesn't that just tell you what your ADL capabilities are? Right? I mean, that's just like a patient who comes in and falls and has a hip fracture. We tell them 50% of patients are going to drop a mortality or a activity level, but 20% will die. Well, is it because they had a hip fracture and that we're not good surgeons, we don't do a good job? No, it has to do with their state of what's actually happening in their life, and that just happens to be associated with it. To me, that makes me wonder if it's more of that. Is it more associated with it? But I don't know. It's a great question.
Yeah, we've actually incorporated grip strength into our clinic as last night. So we actually we love the data on it a lot. So
That's great.
Just to make the PTs happy.
I mean, realistically, that's our goal, right? That's a great point, because I mean, realistically, we should be looking at whole body function, right? And too much where we're focused on, oh, you have a problem with, you come in with, my knee hurts. Okay, great, I'm going to focus on your knee, rather than step back and go, well, your X-ray looks fine, but man, your bone quality is a little bit have you had a DEXA scan? Oh, hey, your DEXA scan was negative, but great, but let's talk about your diet. What are you doing? What's your activity level? Maybe it's disuse osteopenia. Are we focusing on the whole body? And I love that we're looking at grip strength more often, because I think that's a whole body look, right? We're looking at the patient rather than just the symptom. So.
Yeah, I mean, grip strength really just a measure of frailty and how active they are. So my question really is I look at that biomechanically and I'm thinking, any fall on an outstretched hand or catch themselves or something sort of puts that whole thing at risk, right? Because there's nothing back there except for a trampoline.
Yeah, and so the guy I trained with, his name was David Green. He wrote the Handbook in Hand Surgery. And the way he described this is after about 3 months, that space actually fills in. He calls it that it fills in with nature's marshmallow. I don't know why he called it that, but it makes sense, right? Yeah. And patients will ask me, like, well, what happens to that space? And it's like, well, I just usually tell them it's nature's marshmallow. And then they walk out more confused than when they walked in. But realistically, it does fill in. It does fill in with a hematoma. Some people actually put a gel foam cube in there, and then the whole idea is you're creating a lattice form for blood and hematoma to fill in. So over time, they do, not theory, they've seen it where that does have a scarred in tissue ball that kind of fills in that area, which is one of the reasons why we stopped doing that palmaris longus and FCR, because it seems to fill in with nature's marshmallow anyways. So we don't touch it. But you're right, I mean, obviously that puts it at risk, and obviously the question becomes whether it was a suspension arthroplasty or their normal trapezium, would a fall like that have caused damage equally, right? Yeah, I don't know. So, great, thank you.